My name is Brian Schwartz. I'm a professor in the Department of Family Community Medicine and the Dalhousie School of Public Health, and it's my pleasure to serve as the moderator of this next panel on transforming policy to enhance emergency preparedness and response. It's great to be back. I really am so honored, and it's such a great pleasure to come back and see people I've known for decades, people who I met during COVID, and people who I met in my relationship with the Institute. So I hope that, that we continue to have some great discussion. This session will examine how governance, policy, and interdisciplinary research can strengthen health security and preparedness for health emergencies. The presentations and panel discussion will center on two fictitious but realistic scenarios to aid discussion on how governance and evidence-based practice can align to build more resilient and informed response systems. Okay, you guys can already see that my influence is taking hold with this. We're doing little tabletops. The first scenario involves a 36-year-old woman who presents to the local ED with fever, cough, seizure, and bilateral pneumonia. She recently returned from Hong Kong, where she attended a major international business conference, and she's admitted to the critical care unit with pneumonia. By the next day, there are reports of dozens more patients presenting to hospitals in Vancouver, Toronto, and Ottawa with severe flu-like illnesses. There are media reports that at least 6 of the known patients were on the same international flight as the index patient, and that she also attended a large public gathering. Local residents are flooding family physicians' offices and calling Health Connect Ontario with concerns about being exposed. Physicians have been contacting local public health units for information and support. Hospitals are reviewing their infection control protocols and procedures and conducting inventory assessments for PPE, ventilators, laboratory and other supplies, antibiotics and antivirals. The offending agent has not yet been identified. In the second scenario, Ontario has just emerged from a week of very high temperatures, lows over 20 and highs of over 35 degrees Celsius. Dan's not here, I don't have to translate to Fahrenheit. Oh, there you are. That's about 95 Fahrenheit. Increased mortality has been reported in the press and social media. After 3 days of moderating temperatures, the weather forecast calls for another heat wave lasting for at least 5 days. Municipal authorities are calling on the province to increase resources to enable more cooling centers to open. Paramedic services are upstaffing to deal with increased call volumes, and hospitals are preparing to accept overflow patients. Social services are conducting surveillance on the homeless and assessing the safety of older nursing homes, but they are at a loss as to how to avoid heat-related illness in residents. The medical officer of health will be holding a press conference to advise the public to avoid going outside and overexertion, also to hydrate and to check on elderly and shut-in relatives and friends who live in non-air-conditioned residences. We'll begin with short 10-minute presentations from myself, András, Tilcsik, Andrew Pinto, and Quinn Grundy. That will be followed by questions and discussions, questions from the audience and discussion amongst the panel. So we'll try and keep on time. And if I go over 10 minutes, I need somebody to shout and tell me to get off. Oh, didn't realize those were there, great. So I'll start the panel off with some reflections on governance and policy and identify some gaps that are illustrated by the scenarios we just talked about. But first, here is my take-home message. We'll get back to that later, but I should note that we've heard something similar already today from Staney, from Howard, and we also heard from, just looking at my notes here, that from Mina, that something crucial about supply chains, which we're also going to talk about at the panel. Okay. So while planning and preparedness are conducted at federal, provincial, territorial, and local and regional levels of public health, overall governance and funding are largely provincial responsibilities, and the frontline response, though, is largely local. I'll repeat, public health services are really delivered at the local level. That's why I flipped the order here, and should be tailored to specific geographic, cultural, and ethnic community needs. And we've repeatedly heard this sort of the idea of vulnerable high-risk populations that don't have access to but need our public health and healthcare services, whatever the model of funding and governance. In our federated system, as Howard pointed out, provinces and territories are responsible for funding and delivering public health and healthcare services. But there's variation with respect to the delegation of these responsibilities to regional health authorities and the relationship of public health to healthcare delivery. This leads not only to inconsistency between provinces, but also to discrepancies in resourcing and the roles of public health agencies within provinces. For example, Ontario delegates delivery of public health services to local public health units and has a separate funding envelope for public health, while British Columbia includes public health with healthcare services in its regional health authority model. And while the federal government does not fund healthcare directly, it leverages transfer payments to provinces through the Canada Health Act and other levers. But it also provides direct health care to Indigenous populations on reserve, as well as the military. It's also responsible for national security and other functions that are integral to managing specific types of threats. Health Canada and the Public Health Agency of Canada manage the health portfolio for emergency management and have created plans to address threats of national significance. While provinces and territorial representatives are involved in the creation of these plans, historically they've not been updated or tested with regularity, particularly those that involve healthcare impacts but are not health generated. Another issue that Howard spoke to earlier and that we're familiar with is national surveillance for infectious diseases and pandemics. Many of you will remember the post-SARS-1 Naylor report in 2004 that outlined the challenges of establishing a national surveillance system for Canada. It's also the report that led to the creation of the Public Health Agency of Canada. But the absence, as Howard pointed out, of a pan-Canadian surveillance strategy over the last 20 years remains a gap in disease and outbreak management. Okay, in the spirit of public health frontline operations, I'd like to first look at the second scenario, where in fact the public health authority is well situated within a regional or municipal structure and can coordinate with other critical infrastructure partners such as transportation, first responders, social services, hospitals, the media, and private industry. These services collaborate on planning and response in the local emergency operations center to identify and address people and communities who are most at risk, getting them to cooling centers and ensuring their needs are met and followed up. And the response can be integrated with the people and structures with whom public health works all the time. This makes the response coordinated, transparent, and most importantly, accountable. The gaps in governance and structures occur here in the accessing of provincial and federal assets and assistance if needed. We see this, for example, in wildfires and flooding, particularly as they often occur in areas that are remote and home to Indigenous communities. Here we also see jurisdictional gaps between federal, PT, and local authorities. Now I think in some of these emergencies, I think we do very well, but there are still gaps that we need to overcome. In contrast, the challenges in scenario one are jurisdictional due to the scope of the threat. However, the frontline response is still primarily local, where public health authorities need to investigate each case's home, workplace, and context. But in this case, provincial and federal leadership support and the federal and provincial coordination are essential in response to a novel communicable disease that doesn't respect borders, as we lived through during COVID-19. Still, the most effective interventions were thought through and implemented locally based on the best data we could obtain and especially with relationships with community partners. Despite the limited relevance of our pandemic plans at the time and our lack of real preparedness, particularly with respect to logistic and supplies, the exhaustive efforts of people like us resulted in a degree of coordination among key players, at least in the initial stages. The biggest gaps in the COVID pandemic, in my view, were in areas that we were not prepared for, such as long-term care and accessing data on high-risk populations. Fahad addressed this morning. Also, relationships with domains outside of health were navigated ad hoc and lacked coordination and leadership. Increasingly, decisions were not evidence-informed, lacked consistency, transparency, and accountability. I want to turn briefly to some groundbreaking research led by Professor Yasmin Khan, who is at the table over there, on public health emergency preparedness. Yasmin's team at Public Health Ontario has spent the last decade conducting studies leveraging real-world experience, policy decisions, and quality improvement to strengthen public health emergency management in alignment with objectives 3 and 4 of this session. The next 4 slides are courtesy of Professor Khan and were part of a presentation at the Ontario Public Health Convention, March 25th, 2026. Our initial CIHR planning grant in 2015 was used to begin to address knowledge gaps across public health practice settings. We focused on regional and local public health as the front line of Canada's public health system, where preparedness and response are operationalized. The 2 questions that emerged from that study were, number 1, how do we know we're prepared? And number 2, how do we measure it? In addressing the first question, we developed this framework of 11 elements of public health emergency preparedness, surrounded by key processes and enclosed by effective leadership and governance, centered in ethics and values. To address the second question, our team used a modified Delphi methodology to develop evidence-informed preparedness indicators that were both relevant to public health practice and actionable at the local level. The team then developed a workbook as a tool for public health agencies to measure and improve their levels of preparedness. And you can see the date of that workbook was May of 2020. Since the pandemic, Yasmin and colleagues have completed a pilot involving 5 local public health agencies across Canada using implementation science and quality improvement principles to translate this research into practice. So, in summary, delivery of public health services generally and especially in an emergency is local. We are somewhat limited by Canada's federated governments. While we can develop national emergency plans, variable PT models of public health and healthcare delivery limit a consistent and coordinated national response to emergencies across jurisdictions. The use of evidence-informed public health emergency preparedness indicators can measure preparedness and be used to improve performance in a quantifiable, transparent, and consistent manner. I want to acknowledge the members of our core research team, and if you'd like any more information, please speak to Yasmin, who is here with us all day today. So Eisenhower was not talking about public health, but no plan can be specific enough to respond to a given threat. It's the process of planning and the actions emanating from the process that prepare us for an emergency and determine the readiness to respond effectively. There's some references. And with that, I'll turn the podium over to András. It really is a pleasure to be on a panel with a diverse level of expertise. András Tilcsik holds the Canada Research Chair in Strategy, Organizations and Society at the Rotman School of Management. His research focuses on organizations, occupations, and work, and he is particularly interested in the causes and consequences of inequality in labor markets and the workplace.
Thanks so much, Brian, and thank you all for having me here. I'm an organizational sociologist who works in a school of management, and I'm a relative newcomer to this space, so today was a bit of a crash course for me, so thank you for that. So Brian in his introduction mentioned I work on labor markets and inequality in organizations, but I also do this sort of other stream of work that has to do with organizational failure and resilience. And I wanted to share some lessons from that field that might be relevant and at the end get back to the two scenarios that Brian mentioned. And you look at this cartoon from the New Yorker just to remind you that usually when there's a health emergency, sociologists are not the first group that people think of contacting. But I do think there are some interesting parallel lessons from listening to all of you today and then sort of the kinds of patterns we have been seeing in other types of organizations over the last 20, 30, 40 years of research. So I really just wanted to highlight a couple of those lessons. So one of the patterns that we see most commonly in organizational sociology, particularly on failure, is this sort of unfortunately very common and very painful pattern where organizations experience some sort of major failure, they have a crisis, they come out of it, and they learn something, but the learning ends up being very surface level. They end up kind of thinking about proximate causes, they fire some people, they rewrite some policy, they get very good at fixing the particular piece of technology or a particular kind of policy framework that would have prevented that exact specific crisis that they had just experienced, but as a result they end up essentially planning for and preparing for the last crisis rather than the next one. And there's this, I think maybe the most kind of classic and well-known case of this is the space shuttle program at NASA that had these two very different, engineering-wise, very different accidents about 20 years or 17 years apart, Challenger and Columbia, kind of on the surface, totally different accidents, the engineering very different, one blows up, taking off, the other falls apart, coming down. And yet if you kind of dig into the organizational dynamics of what kind of the deeper process that led to these problems, in both cases, they're eerily similar. You kind of see the same patterns where somebody is bringing up an issue and says, hey, I know there's this problem, and that their voice gets suppressed, or even if it's not suppressed, people don't listen to them. Very similar patterns in both cases. If you kind of look at the original documents or the investigation reports of them, sometimes you get confused, like, oh, is this Challenger or is this Columbia? It's kind of those organizational dynamics are so similar. Also another pattern we see that sort of goes beyond the kind of, or below the engineering surface of these accidents in terms of the organizational dynamics is this kind of normalization of deviance pattern where initially we had a policy, we were very uncomfortable with a particular type of risk, but over time we gradually, slowly, subtly reframed it and kind of turned an unexpected risk into an expected risk and then an acceptable or accepted risk at the end. And so again, that same pattern showed up in '86 and 2003 because we were very good at fixing the problems, the superficial or surface level, very important problems, engineering-wise, in '86, '87, '88, but nothing about the deeper organizational issue was really addressed. And then the same, organizationally, the same accident happened some years later. A second lesson we see in this line of work often, and this relates to a number of points people have made earlier, including the Eisenhower quote about kind of planning and what plans do for us and what a good plan is. And so one of the patterns here is that organizations that tend to be most resilient to failure or to crisis use plans as sort of flexible frameworks that they can work from rather than rigid blueprints. And this might sound quite obvious, but I think if you look at on the ground and see how organizations plan and don't plan in reality, not in an idealized form, you often see one or two of common failure modes that goes against this principle. So one extreme is the sort of very little planning about things that could reasonably happen. And in your world, this is probably not as common, but I just pulled out one example. This is from the time a couple of years ago when Associated Press falsely issued an alert claiming that Russian missiles crossed into NATO member Poland, killed 2 people. There was all this sort of very serious concern in the wake of this. The reason I brought this up, because I encourage you to look this up, because someone leaked the Slack messages that led to this, and you can kind of see how planning falls apart in real time, or how the lack of planning about very basic things shows up. So in this case, we see people trying to decide, how do we decide? They're trying to decide, how do we make the call? Who makes the call? Do you make the call? No, this is above my pay grade. Maybe somebody else makes the call. Do we need 2 people to make the call? Or is 1 person enough? And so and of course the whole thing happens in about 8 minutes, but you do get a sense of that. The opposite end of that is the planning process in the Deepwater Horizon, the BP oil spill in the Gulf of Mexico, of America, in 2010, which the Deepwater Horizon had an extremely detailed, very complex, very well-developed set of plans. One expert before the accident described it as a safety expert's dream. He was sort of planning for everything. But it was paralyzingly complex. It was just nobody could really follow it. So when the accident was started to happen and processes started to unravel on the rig, things very quickly devolved into something that's not that dissimilar from what we saw at AP. So we sort of ended up with the same final result, and it seems like the sweet spot seems to be between these two. Plans that are flexible enough, that have some basic pillars in there where we know who'll make a decision if the unexpected happens, or do we need 2 people or 1 person, or kind of how do we do that without necessarily relying on plans as these very rigid, very nuancedly developed blueprints. And then third, one other pattern we've been seeing, particularly in the last kind of research in the last 5-10 years has shown this quite convincingly across a range of contexts, is the importance of cross-role awareness, essentially knowing what other people on your team, what other people on other teams, or what other people in other organizations are capable of, or what their constraints are. That seems to really enhance our ability to deal with surprises, our ability to deal with crises. There's some wonderful research on this from these very different parts of the world. So from film crews, there's a lot of kind of cross-training that people get over time, almost organically. So when a surprise happens and we quickly have to improvise, it's relatively easy for people in the back to kind of step into a role. I can hold a camera well enough, even though that's not my normal job. Or in law enforcement and kind of SWAT teams, in their training, they make a big point of making sure that even people who are not, say, snipers on top of a building have an understanding and get some basic training just to appreciate the constraints and capabilities of what people they'll have to be working with at some point in an unexpected situation have and are capable of and are constrained by, because this type of cross-role awareness, what we find is it does 2 things. One is, in some circumstances, it allows people to step into each other's roles, or organizations to take over a function from another organization, at least for a brief period of time. And second, they, as a result, they allow us to improvise, because I know what resources I can get from you and what your constraints are. And that really helps with that type of coordination. So I talked about these three things. I want to say all of these sound very simple. I like to think of these as simple but not easy lessons. Simple in the sense that sort of cognitively they are not the most kind of groundbreaking, piece of rocket science, but what we tend to find is that it's the implementation. So people cognitively appreciate that these are good and helpful things to do or be aware of, but actually getting it done feels a lot harder. It's just often goes against our natural instincts. So to close, and kind of just raise two questions or 2 points related to the scenarios Brian mentioned. With regard to the first one, I mean, of course, I'd ask a question, as we are thinking about responding to this outbreak, to what extent are we responding to the last crisis, the previous one, not this one? We know that sort of these familiar scripts we sometimes rely on, they make us act and they guide action, but they can also delay our recognition of what's new about this situation and what's different. And then maybe about the second scenario, I would again raise this point about cross-role awareness, this sort of mutual understanding of roles and constraints, not necessarily within an organization, but maybe across organizations, because we do know that does enable real-time improvisation quite effectively. I'll stop there, and Andrew is coming up next. Thank you.
Thank you, András. That maybe simple, but it was very elegant. Dr. Andrew Pinto is the founder and director of the Upstream Lab, a research team focused on tackling social determinants, population health management, and using data to enable proactive care. He holds the CIHR Applied Public Health Chair in Upstream Prevention. He's a public health and preventive medicine specialist and family physician at St. Michael's Hospital and an associate professor at the Temerty Faculty of Medicine. Andrew?
Thanks so much, and it's a real privilege to speak to you today, and lots of familiar faces in the audience. So I'm going to talk a bit about research platforms and share a bit about what we've learned during the pandemic, but actually kind of echoing this point of we need to prepare for not the last crisis we just went through, but what is going to come into the future. I'll kind of segue into thinking about where we're going. And really, maybe a key take-home is that in Canada, we really struggled during the pandemic in general with research. There were some great highlights and lots and lots of hard work that many people were engaged in, but kind of to the point that Brian made, in a federated system, our system is working against us. And just as a stark contrast, our colleagues in the UK went from kind of an initial declaration of a pandemic to enrolling their first participant in a clinical trial in 3 weeks. That is incredibly short and efficient time. In general, in Canada, we really struggled. So part of what it is how do we do much better and really punch above our weight in Canada. So I direct this fantastic team, the Upstream Lab. We're celebrating our 10th anniversary. It's a home for a number of different scientists. Benita's here. She's another scientist at the Upstream Lab. And we have a team of almost 40 staff and also a number of graduate students. And it's really 100% funded by grant funding right now. So lots of different projects and things like that we're all doing. I want to highlight first kind of our work with Cantry COVID as a research platform. So I'll give a huge amount of credit to FAC, to CIHR, public health leaders who quickly saw that we have this new medication, Paxlovid, that's coming down the pipeline. Initial studies really run by the drug companies themselves that say it's going to reduce hospitalizations and deaths, and it's incredibly expensive, $1,400 approximately per course. So, you know, colleagues across Canada, in I think a really good way, said we need to do a study. We need a trial that really looks at this. And so CIHR had a special call. We were very fortunate to be the group that was awarded this funding. And we ultimately recruited about 800 participants from across Canada. We studied both Paxlovid and also an antioxidant therapy. And one of the key things is with an adaptive platform trial, it's very flexible and actually can continue and be ongoing and allow you to study different treatments. Really a huge kind of efficiency because you're not starting from scratch with every trial. And our findings a few weeks ago were published with Panoramic in the UK, a very similar trial. And we worked very closely with Panoramic to align our work. But the two trials were published together a few weeks ago. What do we find? That now in a highly vaccinated and highly immune population, didn't reduce hospitalizations or deaths, but did result in slightly faster recovery. We also have some other findings coming out around things like long COVID and the impact of it on that. But we hope that the evidence is going to support more targeted uses of this therapy. So thinking about kind of scenario one and the future, what would it look like if we have these platforms up and running ahead of a pandemic? So that's where we're now moving to. So we've started to build the foundation of TreatResp, which is an ongoing adaptive platform trial ready for the next emergency that is there to evaluate treatments for any respiratory pathogen, including existing ones like seasonal influenza or COVID, but also disease X threats. And we've learned a lot from our colleagues in the ICU settings with REMAP-CAP, and they've been very generous in sharing kind of how they set up a similar system, and it's working with a number of colleagues in different countries. So just getting underway, we actually just began and got approved to begin recruitment last week. So starting to see this, and we're beginning with influenza, for example. Another research platform that we're leading is this initiative called Prepared. It's funded by the Canadian Biomedical Research Fund, so a federal funder. We were one of 19 teams that was supported, and it's based at the Upstream Lab with the support of U of T's Hub for Health Intelligence and Innovation in Infectious Diseases. There are a few key parts of it, but I'll just emphasize two or three of them. The first is it's an active surveillance system. What it includes is having staff who are trained, who are based in emergency departments. We involve pharmacies, large primary care centers, and now a home testing system where people who have acute respiratory illness actually are swabbed. They first have a rapid antigen test done, and then a swab is sent for PCR analysis with genotyping of a select number of those samples. And this is really ahead of a future pandemic, would be very, very valuable to have sources of data which we don't have right now in Canada, particularly people in the community. So many of you will know we have actually fairly good data when people are hospitalized or there are outbreaks in like a long-term care home, but this is the vast majority of infections when people are in the community as well. We're combining this with plans for an automated syndromic surveillance system using electronic medical record data. And it's building kind of the foundation for something called Pisces. It's learning and kind of leveraging what has been learned with Gemini and Vital, which you heard about in the morning, to envision a similar system for primary care. Lots of challenges to overcome with this, and we're getting started slowly here in Ontario and kind of laying the groundwork in Alberta. But the goal will be is to have primary care organizations and clinics having control of their own data, and then with their authorization, bringing it together in a very secure way. One of the other key parts of prepared is when people are being tested, if they test positive on a rapid antigen test for COVID or influenza, and if we are in treat rest, actually studying a therapeutic, we're able to immediately tell them and say, you've tested positive for flu or for COVID or disease X, and we're actually studying treatment for it. So you can see there's a link between these platforms that we've established. So that's, I think, another really key piece of this. The last thing, which we haven't talked that much about, but which was kind of hinted at, was about supply chain and our own Canadian capacity to create therapeutics, to create diagnostic tests. One of the interesting things about Prepared is if you are creating a new diagnostic test or a new therapeutic or you have a new vaccine and you want to get Health Canada approval quickly for this, this would be a great platform to be able to test it against a gold standard. What we see though is we also want to make sure that there's a fair return on this public investment to the Canadian public. So aligned with starting to talk with different manufacturers, we're also creating a framework that says how do we make sure publicly invested platforms like this, there's also a return to Canadians. A very simple thing would be, okay, if we're testing and helping validate your new diagnostic kit, we want to make sure you're giving a good price to governments, to public health units, or others who are purchasing this, and that being part of the negotiations. So Prepared, in our first real season this past year, we've had over 28 sites. There are a mix of different sites that are up and running, and you can see the types of kind of information we're starting to collect as we go through. We had more than 1,200 people in this first year, and we're hoping to grow that to more like 4,000 or 5,000 every season. So just to conclude, I think that we have some, lessons from existing platforms, but we're really thinking about the future. We have these platforms, Treat Rest, Prepared, Pisces. We're inspired by platforms and initiatives in other countries, particularly the UK, Norway, and Australia, where they're doing incredible work and where we know it's possible to do much better. As was mentioned, the Naylor report, the more recent Walport report about how Canada's science kind of responded to the pandemic, and several of the chief medical officers of health reports all suggest that we really need these types of real-time research platforms. And what is it going to do? It's going to make us better prepared and improve our response. It'll really help with the efficient use of public funding. It'll actually bring that lens into this work. It'll link public health, health system, and research goals. And I think it's important to say it could help with economic goals. There's a huge, buy Canadian movement and Canadian manufacturing. How can these research platforms, which are publicly funded, help support that? And of course, this requires trust, partnerships, good governance, and shared values. For example, that there's a collective agreement that we're going to share or collectively own the intellectual property. So I'll stop there and look forward to the questions. Thanks.
Thank you, Andrew. Really, really exciting stuff and an example of a planning framework that's indispensable for the next emergency. Quinn Grundy is Associate Professor in the Lawrence Bloomberg Faculty of Nursing. Her research explores the interactions between medically related industry, including pharmaceutical and medical device companies, and public health systems, and the implications for the delivery of health services, health evidence, and health policies. My pleasure to welcome Quinn.
I'm a bit shorter. So I feel like when people hear the word governance, we get a picture maybe of like dusty manuals and red tape, but it's not the most jazziest of terms. But in the next 10 minutes, I want to make the case that strengthening good governance in the public interest is critical for emergency preparedness and response. One of the hats I'm wearing today is as director of a World Health Organization collaborating center with a focus on governance, transparency, and accountability in the pharmaceutical sector. And they've broken out as social scientists for this panel. I'm going to speak to the three of our ongoing projects that really look at some of the core questions that we're grappling with around the processes by which we research and develop, approve, select, price, fund, procure, and monitor health products. And so I'll speak to not just medicines, but medical devices, blood products, PPE diagnostics. And in the scenarios that Brian presented, I think it's evident that health products are critical for the delivery of primary care, universal health care, but also at times can take up a disproportionate focus in terms of budget impact at the expense of things like infrastructure, human health resources, and other investments. So I think to convince you of the excitement of this topic, it's maybe illustrative to look at what happens when governance perhaps fails. We can see health system wastage, gross inequities both within and among countries, and an erosion of public trust in processes and institutions. And I think particularly in emergency situations, there can sometimes be justification to bypass, discount, accelerate in the name of efficiency or security some of these core and fundamental principles. So I want to argue that strong governance is really critical and a priority in order to ensure access. And I think you've had conversations already today about supply chains and safe, quality-assured medicines. We're speaking already in this panel about the importance of stewardship of scarce and valuable health system resources and to ensure the sustainability. And then not just to promote, build, maintain trust, but to make sure our processes are, in fact, trustworthy. And so to set the stage, I think that even the Sustainable Development Goals really kind of emphasize these three principles when we're thinking about governance at this 50,000-foot lens. Transparency, the idea that information about not just the outcomes, but the process itself is made public. It's an end in itself, but also instrumental for accountability, participation. Accountability, very basically, that we would set out as decision makers, institutions, our commitments, our standards, report and be answerable for those actions, and face consequences if these are not met. And I think underlying this is the idea that these processes are responsive, inclusive, participatory. I love this idea of a civics course, even at the post-secondary level, understanding how decisions are made and how we take part in this, and ensuring that these processes center the people they serve and that publics can hold them to account. And so one area of work that we have been tackling at the moment is this idea of transparency and transparency as an environment. Back in 2019, the World Health Assembly actually passed a resolution calling on member states to implement laws and policies that bring greater transparency to the medicines price, but also value chain. And this is an image from Médecins Sans Frontières that illustrates really that the status quo is secrecy, non-disclosure at almost every stage of a health product's life cycle, which for people from local procurement committees to national governments to international organizations, it has created critical information asymmetries, power imbalances, and inequities, again, between countries. And huge challenges for accountability in terms of being good stewards of public dollars and ensuring affordable access to essential health products. So with WHO, we actually have kind of done a deep dive into 3 country case studies, Canada, South Africa, Italy, as jurisdictions that attempted to bring about any sort of transparency to medicines prices, and really trying to glean some lessons about how do you put these principles into practice. And I think while we're talking about kind of some national things at the moment, many of these principles and practices work from the institutional level up. So first of all, though, we see the importance of supportive legislation. In South Africa, for example, their constitution has transparency as a right, and civil society took the government to court and had them make public the vaccine procurement contracts. And that allowed the world to understand really the extent of price discrimination. South Africa paid more per dose than many European nations. And I think when we see a transparency, really, it is a collective action problem. We have global supply chains, we have multinational industries, we have crises like global pandemics we're trying to meet. And so when countries and policy actors formed coalitions or took collective action, things in Canada like our joint price negotiation and the Pan-Canadian Pharmaceutical Alliance or joint procurement mechanisms, finding ways to share information across jurisdictions toward things like affordable access. We also saw that a suite of other levers. I think Andrew's just mentioned this idea about licensing and agreements when we are looking at new products, how to ensure the public gets a return on its investment, how to ensure that transparency can be acted upon. I think in addition to transparency and accountability and participation, another kind of key concept that is really critical for governance of pharmaceutical and medical device sectors is independence. This is a lovely graphic from a scoping review that illustrates how technically complex and the extensive interaction there is between the private sector and the public sector, everywhere from our medical education through to our public sector pharmaceutical committees, the healthcare system, and medical supply chain in between. And currently, we rely predominantly on market-based mechanisms, commercial incentives, to deliver access to essential health products. What products are researched and developed, whether a manufacturer will even bring that product to market, which is often a key challenge for Canada, which is not a large market. And then whether public products, are considered for public reimbursement. And I think Andrew's point too, highlighting that even much of our research, what we know about the effectiveness of products is coming from the private sector. So one major area of our work is really trying to understand how for-profit commercial entities, their intermediaries, are shaping these processes. And I think what we see in the result is often our preparedness and emergency responses are very technically oriented toward vaccines, PPE, instead of things like public health basics, infrastructure, human health resources, the social things. And I think increasingly we're seeing market failures arise, whether that's antimicrobial resistance, to not being able to access critical and innovative diagnostics in small markets. So one study we did in the COVID-19 pandemic was to look at examples of alternatives to commercial biopharmaceutical research and development. And I think this is a growing area of work, including for manufacturing and other areas of a medicine's life cycle. How could we do the governance differently? What other models exist, whether those are not-for-profit, different forms of partnership, or public? And so I don't know if any of you remember that moment early in COVID when we looked at convalescent plasma as a potential therapy. So the idea was someone would have COVID, they would take their plasma, transfuse it into someone who was exposed, and that I believe it was going to give them a boost to fight that infection. In the end, it didn't work, but what happened early in the pandemic was a number of public sector funded and led clinical trials, including in low and middle income countries. And many of these were the adaptive trials that Andrew just mentioned in his talk, including the UK's trials that were able to enroll people within a matter of weeks. And although these, they were not perfect and these happened under emergency conditions, I think they were qualitatively different. And we did kind of a deep dive into these processes, finding that if we think about public sector innovation, there were different outcomes. There was certainly an orientation toward more open science and that direct link to practice. We also saw for example, investment in infrastructure, so a return to the public beyond the results of the trial, into blood systems, into health systems, into research capacity, an ability to kind of prioritize values in the public interest. One of the reasons they picked convalescent plasma in the first place was that it was affordable and there was no IP, so they had access and could test this. So I think another kind of area of work and a challenge in practice on the independence point, and many of you who are working in public health departments and offices may have the task of forming committees and finding experts and wrangling these experts as we seek to have evidence-informed decision-making. But one of the consequences of having a really technical sector and the prevalence of interaction with the private sector is struggling to find expert committees that are free from financial conflict of interest and are independent. And this is particularly true in small fields or in small countries. And so I think one thing that we have worked on and doing research is this idea of how to start to create this norm of separation, to develop frameworks where you can have interaction, you can have collaboration, but which prioritizes independence and transparency and integrity of that decision making. We did another study with the WHO. In this case, it was in countries in the Southeast Asia region, but there was nothing, I think, that was not applicable to Canada or other countries in the world. And I think there is a strong awareness of conflicts of interest. And there's now, I think, for many of us, consistent disclosure requirements, but these are rarely made public. And I think we still don't always know what to do with that information, how to actually manage these relationships, and very much less emphasis on prevention of these sorts of conflicts. And I think this is something that maybe people have heard or talked a lot about, but it's something we really still haven't dealt with. We've come out of an opioid overdose crisis, we've come out of COVID-19, we now have widespread vaccine hesitancy. It has multiple reasons, and I know the next panel will really take up some of these conversations around public engagement and communication. But I think until we really deal with these conflicts of interest and independence in the context of a transparent and accountable decision-making processes, we will struggle to regain that trust. And so just to conclude, I will say that I think what we've also seen recently is how easily governance is dismantled, and that this is something that we can't put in a manual but needs constant cultivation, including education about one's role as a participant in these processes, understanding who is a decision maker, what are their accountabilities, by what process is decisions made. And I think it's something that we need to be building capacity about, even in our professional workforce, let alone before they get to the place. Transparency is very politically challenging, no matter your colors on the political spectrum. And so I think we see this as something we need to bake into our legal, our regulatory, and our policy and our processes so that it is already in place long before an emergency. I think as we identify these levers for independence, we need to make this a norm. We need to adopt this in practice and kind of celebrate this as a strong foundation for this. And I think in Brian's scenarios at the beginning, ideally when there's an outbreak like this, people do come to public health, people do come to the healthcare system. People are within community seeking for help, but I think this will require a shift into understanding really how we can be trustworthy as we come out of some of these pandemics and hopefully prepare for our next emergencies. So, thank you.
Oop, not yet. Thank you, Quinn. A really insightful peek behind the curtain on pharmaceutical availability. Okay, we'll open it up for questions and answers and discussions.
Great, thanks so much. 3 wonderful talks and good scenarios. Maybe for András as a question, one of the things we saw in COVID that was actually a very useful organizational change for many of us in healthcare was being able to override union contracts, to be able to redeploy our workforce in a difficult way. And we don't like to do that. It's not a pleasant thing to do, and we don't want to have to do that. It's sort of for emergencies only, but it was useful. But people don't seem to want to hard bake that into future planning, to say, what have we learned that could be adaptable to future emergencies, right? We don't want to plan for the last one, we want to plan for the new one, but this kind of tool that actually allows the flexibility of workforce is probably going to be useful whatever that next emergency is. But there's an organizational feeling, obviously, it's not a pleasant thing to do, to want to have to kind of go around that. So do you have any advice from your sociology background as to how we can sort of start to bake these kinds of difficult decisions into our emergency planning?
Yeah, so that's a great question. I think, one pattern we sometimes see is that, again, back to the Eisenhower point, these things sometimes don't make it into the plans formally in a kind of very crisp and baked-in way, but informally, there's an understanding that gets developed from the planning process around it, and those conversations still happen. So when the time comes, to the extent that we can deviate from the letter of the plan, and it can become part of the sort of institutional memory that might still allow an organization to implement these things, even if there's resistance to formalizing it, right? And sort of conversely, we see a lot of the other kind of the opposite side of the same coin, where a lot of things get baked in that we don't really do when push comes to shove for various reasons.
Eileen?
Just quickly answer, Michelle. I was going to do a little add-on to your question, Michelle, because it's something that's actually, we're facing the Public Health Agency of Canada. So there's no perfect answer. And all of us who survived COVID-19, a lot of us like myself are gone, retired, pushed out, whatever, right? So maybe it's a bit of a sort of a hard reset in terms of the culture, because there was discussion before I left, and I don't know where it's at now, that for all new incoming employees, their actual terms of employment actually indicate, yes, you are hired as an epidemiologist in chronic diseases, but in case of a national emergency, etc., you are expected to then work in the Emergency Operations Center and be part of the overall all hands on deck. So that's, I'm not sure if it's a culture shift sociologically, but maybe that might be the posture that an organization takes, especially new incoming. Can't speak to the people already there, but at least that's maybe a change in the thinking and the culture.
Thank you. Thank you. Eileen?
Thanks, Brian. And, clearly those of us who survived COVID-19 have the same idea on the brain. I had essentially the same question, but expanded a little bit more. So Andrew, in your conversation, you talked a little bit about experiences or learnings from other jurisdictions. I think you talked about Norway and the UK. So András, to the same notion, right, but with respect to what you presented, Michelle asked a very specific question around unionized contracts and what people are able to do. But you talked about three broader concepts that are important in terms of being prepared for whatever eventuality faces us that is challenging and complex. And my sense was that there's a lot of work done with respect to what can be done in organizations that are perhaps more reflective of what occurs in the private sector. And as I was listening to you, your ideas all made great sense to me. And they seemed completely anathema to the way things actually work in the public sector. And some of that is around governance. Now to bring it to Quinn's conversation, clearly the governance of these organizations within the public sector is part of that. But I was curious to hear from you whether in your research you've seen jurisdictions where the kinds of principles you're talking about are well reflected and sustained within public sector organizations.
And that's a great question. And you're right, a lot of the work that's been done in my field on this, many of the success stories or kind of partial success stories, I don't think that there are many fully unqualified success stories, but many of the partial success stories have come from the public or private sector with sort of fewer constraints for various reasons. But I think, even among the kind of public sector organizations, some of the ones I've talked about, you have seen some progress. Like I've talked about the NASA case, for example, right? Sort of the space shuttle program. They've had it took two accidents, but the second one did start a cultural change and sort of a very open conversation about these deeper issues, ultimate causes, kind of how do we listen to people who don't have the perfect expertise but have a gut feeling that things are not going so well. And so there are these sort of partial successes. I've seen some in, I don't know, departments of correction that had a big failure or kind of a near failure and kind of recovered from that and then took some of these lessons more seriously. Unfortunately, my experience is that it even in the best case scenario, it often takes a big failure or at least maybe a little better scenario, a similar organization experiencing a big failure where it scares me enough, but I'm not defensive, too defensive to sort of start to change. So that's kind of where I see often there's a window of change where you can kind of make the case to decision makers, hey, this happened to our, in some compelling ways, parallel or analogous organization, and we might be the next. So let's do something about that in kind of following some of these principles. Maybe others have. Andrew?
Yeah, I'll just add to that, and thank you, Eileen, for the question. I guess two thoughts on the public sector. I do think we can be inspired by other countries that are similar enough to us, but are doing things that are quite remarkable. So just to speak about Norway, the Norwegian Institute for Public Health recognized that during the pandemic, we essentially had very little evidence around things like school closures, mask mandates, and so on. And of course, it's a smaller country, and there's many things you could say. They're not a federation, et cetera. But they still were able to bring people together around this idea to say we could actually use randomized approaches to study the effect of these types of things. And they were able to make some headway. And actually evaluate rigorously. And they're one of the few countries that I found was really doing that and embracing that. So I feel like that model could be very, very helpful to us, that it is possible to do. I guess my second point is what Canadians need really to do this is they do need that kind of example from our outside. They need to see that it could work, but they also need the alliance of people all working together to say, we really want to do this. In Canada, for example, the Urban Public Health Network, which you and many others are part of and have been part of for years, I see that as a very powerful group to align, kind of saying, we're going to go for this. We're going to actually embark on this type of thing. I feel like that kind of more upward pressure starts to challenge things. It's hard, and there's no easy solution, and there's funding shortfalls and things like this, but it allows us to kind of break out of the boxes that we're often in to do that. It ultimately is kind of like the question, what sort of norms did COVID change? And how do we exploit that change, that kind of space that's been created to try something different?
Great, thank you. Any other questions?
Hi, thank you all for your presentations. They were very informative. I think my question's more tailored to András's specialty, but so we come from a local public health unit and we work in emergency management. And after each emergency, we conduct after action reviews to just identify pain points, what could have gone better, what could have maybe been improved on. I don't think we've had a Challenger level disaster, but do you have any suggestions on how to go about finding what you called those ultimate causes rather than the proximate causes when we're conducting those after action reviews and doing those debriefs?
Yeah, and I'll try to be quick. I don't want to monopolize the response time. So two things come to mind. One is asking this question, what is this an example of? This broke, okay, what is that an example of? Is that an example of something broader? I think, and then once we get an answer to that, ask again, what is that an example of? Is that an example of this particular branch of our organization failing, or is that a kind of is it an example of a broader process where, I don't know, there's cross-branch communication problems? The other thing I'll mention is we do see that organizations that learn these ultimate causes more effectively tend to do very kind of blameless postmortems where they kind of culturally lean into that and they say this is blameless, it's not about that. My favorite example of that, it's a private sector story, but it's from Etsy, the e-retailer that sells art. In their engineering team, they have an annual award called the Three-Armed Sweater Award, where you get a three-armed sweater as a symbol of failure for being the engineer who broke the website in the most spectacular way. But you get to give a kind of TED talk to the whole engineering group with the recognition that we are all trying to be better. The failure is not your negligence. In fact, you were trying to deal with this very complex problem. And I think that sort of blamelessness baked into the culture does help unearth some of the deeper causes.
Maybe I can add something. It's great that your organization is conducting an after-action report and plan. It's even better if organizations can come together and look at the system and see where the system failures were, whether that's on a local, provincial, or federal level. And I have not seen a lot of that since COVID. Other questions? Well, while you're thinking one, I've got one for Andrew. In a previous life, I remember meeting with a number of critical care physicians after SARS-1 and looking at platforms to do research on life-saving medications and system issues with respect to access for critical care. It kind of petered out after a while. How do you see the platforms that you're evolving with current, at least, support being sustainable?
Yeah, it's a great question. It's interesting because András, your example of the two spaceship disasters makes me think a bit about in Toronto here. We had SARS-1 and then we had COVID, and there's a lot of replication. But also, could this be a different moment so we're not just kind of resetting back? But to answer your question, of course it's a massive challenge of how do you sustain platforms between emergencies. We know that if, say, this coming season there was another massive pandemic, we would again have this boom cycle of funding. There would be lots of people applying for funding. There would be these things that get set up and then they come down again. So I think a couple of thoughts on how you sustain it. One is really thinking of multiple uses of platforms. So the example I gave of Pisces, and similar to Gemini and Vital, the thing is these are not only for emergencies or only for syndromic surveillance and pandemics. They can be used for many, many things. Gemini really began as a quality improvement initiative for internal medicine physicians. And it can be used then for a whole bunch of things. With Pisces, we're really thinking of it primarily first as a mechanism for patients to access their own data, which is going to be an ongoing challenge and something that every Canadian will need over time. But secondarily, it can be used for a lot of others. So that's, I think, one piece. I think another piece is diversity of funding. So looking for funding from different strains. There are a lot of for example, foundations that are really interested in Canada being better prepared, or Canada being much better at improving our own local made in Canada kind of manufacturing capability. So that in addition to the kind of traditional research funding and things like that. And I guess lastly, Canada is a relatively small country in terms of the population and the networks. So I think that's a strength of ours. We can actually know a lot of people in a relatively small community. So let's use that to our advantage by trying to see these platforms as something that people are all aware of, but also that there's kind of a democratic access to them. Many of these platforms, it's like, we've built it, but you can use it. Like, please come and engage with it. So with Prepared, I was talking with Nelson earlier that there are colleagues from across Canada who are working in everything from basic science to diagnostic development to vaccine development to classic kind of epidemiology. Invite all of them to engage with this platform, and then that helps sustain it as well. And those are probably the most successful platforms, are where it's not owned by one group or one team, that it's really this kind of democratized platform.
Thank you. Okay, any last questions? Go ahead.
Hi, great conversation. Your last speaker spoke about greater transparency and accountability in terms of public health responses during a pandemic. And one of you earlier talked about the importance of not excluding vulnerable populations in terms of planning and addressing gaps that they may face. And you talk about some of the learnings or some of the best practices that may be used in other jurisdictions that kind of make sure we don't decenter or exclude vulnerable populations in this work?
Yeah, thank you for that. I think in our work in this area, what I have come to appreciate, I think we've already challenged this notion of things being evidence-based, but rather evidence-informed. And realizing that we have pretty narrowly defined expertise. And I think for many years have now talked about how to have more inclusion and representation in expert committees and guideline development processes and this sort of thing. But what I think happens is that we still, in many of our processes, people that are well-sponsored, coming from those views are amplified, and we haven't yet quite figured out how to really meaningfully engage diverse forms of expertise and to center the people we serve in these committees. So I think often when we are forming something, whether it's a national vaccine advisory committee or whatever, we think of expertise that is maybe most proximate, ready to hand. Okay, we need a vaccine manufacturer, we need a supply chain. And it wasn't until much later in COVID that people were going into communities that were disproportionately affected by COVID, did not have access to the vaccines, but did the work in the community on their terms in the way that made sense to them, in the places that made sense to them. And I would like to see, I'm thinking right now of the clinics that were set up in Brampton, and finally, but that was later in a later stage of the pandemic. I think globally with the vaccine inequity and the rollout, we have learned nothing from, I mean, we've learned a lot, but have we put this in practice? We're still trying to kind of hammer out the pandemic treaty internationally. And so thinking about the next one, I would really hope we could see some accelerated action on this. Globally, I think this push to kind of security, nationalism, domestic, is going to work against some of these things unless we think of this as kind of public sector-led, collective action problem. And then I think more locally, turning it on its head and actually going to the communities that are disproportionately affected and beginning the planning and response there.
Can I tell a little personal story about that? This is a closed room, but many people know this story. When Steny and I were putting together the Ontario Scientific Advisory Table, we populated it with a lot of suggestions from deans of medical schools. And we realized when we put it together that this is not a diverse group. And we knew that would be a problem for many reasons. And we decided to go ahead anyway because of the urgency, because we were really behind the curve already. And then about 8 months later, as we're plugging along, we got these data from Kevin Brown and others from the university and from Public Health Ontario that showed the areas, the geographical areas that were getting clobbered by COVID-19. And they were high-risk areas. We know what these areas are now, and they're the areas that weren't getting vaccinated. They're the areas that weren't getting health care. They're the areas that weren't getting public health services. And we dove into those to try and figure out how to get them those services, because we had to. And by doing that, we learned what those community needs were, how to get through to these communities. We learned that from public health organizations locally. We learned that from community organizations locally. We brought people from those areas to the scientific advisory table. We channeled that information to decision makers. And I think it led to a better, if not ideal, outcome. That was a huge, huge lesson. And if we can't incorporate, I think we have to some extent realized that proactively we've got to deal with these populations, but it's an example of how we need to be diverse, how we need to be proactive in looking at their needs, and how during an emergency, how important it is to incorporate lessons learned in real time so we can continuously improve the situation and continuously plan, as we've talked about, for the next emergency.